from USA. That's Peter Waters and Maribeth Izaki. Both are expert on the topic. And in addition to that, we have two experts from India. That's Jayan Sampath and Chaznal Rathod. I will give a brief introduction about our faculty. Carley Vuillermin, she is actually a postgraduate student of Australia, but later on she migrated to USA. And at present, she is a consultant at Boston Children's Hospital. Her major area of interest is upper extremity problem, particularly the neuromuscular and the deformity of the upper extremity in children. Her major focus at present is validation of a score, that PROMIS. That's a patient-related outcome measures, information instrumentation. In addition to that neuromuscular condition, she has also done a great analysis of outcomes in radial longitudinal deficiency. And her recent observation has really made a significant change in the management of this condition. Peter Waters is actually a good friend of POSI, and he had been to India in 2013 for the POSICon 2013 at Ahmedabad. At present, he is a John Hall professor at Harvard Medical School and chief of surgeons at Boston Children's Hospital. His expertise is a pediatric upper extremity problem, and in that, obstetrical brachial plexus palsy is his main area of interest. He has more than 250 publications and also authored or is an editor of 3 textbooks. His 4th book is on the way, and that's Pediatric Orthopaedic Reconstructive Surgery. In addition to this great academic qualification or the achievement, I would just like to say something about his commitment. When he was in Ahmedabad at the time of 2013 POSICon, he was supposed to show a cadaveric demonstration of some surgery. In the morning, he was not well. He had some intestinal infection. And we asked, like, will you be able to carry out the demonstration? He said, yes, I will try. And for 4 hours, he demonstrated minute details of the surgery. And after the 4 hours, when the demonstration was over, he was completely exhausted and he had a very high-grade fever. In spite of that, he was committed and he carried out whatever he was supposed to show to the delegates. So I really appreciate his commitment. Today also, he has made a great adjustment to make possible to attend this webinar. Maribeth Izaki is another expert on the topic. She's a consultant at Texas Scottish Rite Children's Hospital in Dallas. She is professor at University of Texas Southwestern Medical School. In addition to pediatric, he has another area of interest, that is upper extremity problem in adult patient. There are very few surgeons at present in the world who are focusing on the adult problem of stroke, head injury, a spinal cord injury patient, or other neuromuscular disorders in adults. He has also contributed to the famous textbook of Tejian, which all of us read as a standard Bible of the pediatric orthopedic. So I welcome her. The 2 faculty of India, the Jayan Sampath, he practices at Bangalore. He is an editor of our journal, POSI journal. And today we are going to unveil the first issue of our journal, that's the International Journal of Pediatric Orthopedic. He's really a passionate for gait analysis, and I consider him a Jim Gage of India. He's so passionate about spreading the awareness about use of gait analysis in cerebral palsy. So that is his major contribution to the field. We have another young pediatric orthopedic surgeon, Chaznal Rathod. She practices at Mumbai, and she practices at Jupiter Hospital and SRCC Hospital. And at both the hospitals, she looks after the cerebral palsy patient. She had done a fellowship at Seoul, Cincinnati, and Toronto. And she is also a visiting scholar of POSNA, SICOT, and American Academy of Cerebral Palsy Developmental Medicine Association. If those who are watching this program on Facebook or on YouTube, they can ask their question on the number that's 98203 29888. Once again, I repeat, 98203 29888. Before I hand over to Carley for her lecture, I would just like to brief you about our next webinar. Exactly 3 weeks after the today's webinar, we have another webinar on the recovery of growth plate after the growth modulation. And we are very fortunate to have 3 experts from various parts of the world. Ignacio Sempera from Spain is going to be the key faculty for the webinar. Then we have Peter Stevens, the person who made growth modulation very popular. And then we have another expert, Berne Moller Madsen from Denmark. So please note this date in your planner and we will definitely inform you about that. So with this, I hand over to Carley for her lecture. Thank you.
I will just share my screen.
Yeah, please. We can see your screen. Make it full screen.
Yep, there we go. So thank you very much for the very generous introduction. It's nice to see both familiar faces and also new faces today. And it's actually an honor to give this webinar with 2 of my mentors, as well as many other people that I have worked with. I look forward to the webinar and I will be drawing on our experts during my talk for some of their hopefully brief ideas. And then we'll expand on that with our cases from our local experts later. I don't have any direct disclosures, although I always have disclosures that people have influenced me, and 2 of these people are here today, and 2 of these people are great friends of both cerebral palsy and also POSI. Kerr Graham needs no introduction, and Ian Turode, although no longer with us, has influenced my career greatly. I am going to go through a fairly structured standard presentation on cerebral palsy upper extremity so that we cover everything, and then we can delve into some deeper issues with our experts towards the end. I will give some take-home points. I think that it can be very helpful at the end. So we'll start with evaluation, which really to me is the most important part of determining how I might be able to help a family and child with cerebral palsy. Hands are very different to feet, and they're a lot less constrained, and we use them in a very, very different way. We interact with our environment, often without actually even looking at our hands, and we're doing a lot more fine motor control and complex tasks. I don't think anyone ties their shoelaces using their contralateral foot, but we always tie our shoelaces using our hands. Additionally, and I think this is even more important in the pandemic, our hands are actually the second thing that people notice when they meet us. And I think that the psychological impact and the self-esteem always is part of my assessment of how a patient with cerebral palsy can be best helped. I would say that this is a really difficult group of patients, and all of you know this. Patients come to the clinic. Sometimes they're very nervous in the clinic. Sometimes they've had other hospital experiences that make them different in the clinic to what they are at home. I find that it just takes time. It takes some distraction. It takes talking about things outside of the examination room, and then multiple visits, because we all know somebody can be having a really relaxed day or a really high tone day. And so making decisions based on 1 or 2 observations to me is too difficult. One of the our experts in this webinar gave me this piece of wisdom that in actual fact, what we call making our best judgment is actually the cumulative experience of our experiences and our wisdom, but particularly our bad experiences. So when I meet a patient with cerebral palsy, patients have very different levels of ability and the way that they use their hands and the way that they work either as an individual or as a family unit. And to me, the 2 most important questions that I ask is, does the patient use the hand, or does the hand get in the way? And does the patient use the hand can mean, do they spontaneously use the hand? Do they use it to actively assist, or do they use it to passively assist, or more what I call a paperweight function? And in terms of getting in the way, how do they get dressed? How is hygiene? Do they get skin breakdown and maceration? They're really the main questions I'm always aiming to answer so that I know what the goals for this patient will be. Of course, the type of neuromuscular disorder is very important, and the motor pattern. We all know patients who have very mild hemiplegia who really function exceptionally well. We also know patients who have mild leg hemiplegia, but actually have a heavily involved arm. It's important to determine what type of motor disorder there is, because spasticity is what we talk about most of the time when we're talking about interventions. But if you've got a lot of dystonia or athetoid movements, then surgery needs to be encountered in a very different way, and perhaps at a much different cadence, even avoiding surgery in some patients. It's also important to consider the patient's stage that they're at, their capacity for being involved in decision-making, and also it has been shown, it used to be that people would say that below a certain IQ, you shouldn't be doing tendon transfers. It's been fairly well shown that it's not based on intelligence, it's actually based on the engagement and the ability to participate in the rehabilitation. We, as orthopedic surgeons, we're very good at thinking about motor dysfunction. That's kind of what we base our life around. And for cerebral palsy upper extremity patients, it most certainly is imbalance. Although there is high tone, the patients are actually weak, and there is joint instability that develops secondarily. But the part as orthopedic surgeons that we will never overcome is that control, the control of the limb that comes from the central nervous system. So we're really looking at the peripheral manifestations of a central nervous system disorder. Almost all patients with hemiplegia do have abnormal sensation, even if patients, when you test their sensation, say it's normal. Additionally, thinking about the different associations with geographic CNS lesions, neglect and visual field defects can really impair how somebody uses their limb. So ultimately, when thinking about assessing a patient, I'm looking at the level of motivation. I think that even more than in the lower extremity, patients need to have a high level of motivation, or patients and their families. I need to know what the goals and expectations are, and I spend a lot of time on that. And sometimes if I get a sense that patients don't understand what I might be able to help them with versus the things that are part of their overarching diagnosis of cerebral palsy, I'll have them make a task diary and come back, so that then we can actually talk about the things that they have trouble with, and then I can outline the ones that I can help with and the ones that I can't. We, as pediatric orthopedic surgeons, are all familiar with this great chart that comes from the Royal Children's Hospital in Melbourne, although the development was not primarily there. But the upper extremity doesn't necessarily follow the lower extremity. And so therefore, describing someone's GMFCS level doesn't necessarily tell us what to do with the upper extremity. Traditionally, we have used the 8-point house classification, which goes from the person who just doesn't use the limb at all, a poor passive assist, so a paperweight function, right up to the patient that really, it's very hard to tell that they actually have cerebral palsy and that they use the hand normally. We'll go through this a little bit more in a minute, but this is actually very single activity based. It's not an overarching description of how that patient uses their hand on a daily basis. This is applied usually to single tasks. So the manual ability classification system is a newer classification system. It's very like GMFCS, and that's why I really quite like it. And it actually does globally describe how the patient uses their hands during regular daily activities. Right from handles it easily, which is your GMFCS1 patient who runs up the stairs without any difficulty, to the patient who doesn't actually use their hand for anything at all, or doesn't have volitional control of any description for the hand. When looking at the assessment, usually by this time I've come down to having a patient that fits into one of three different major categories. One is the high functioning upper extremity in a hemiplegic patient. And these are usually GMFCS 1 or 2 patients with an MACS 2 hand. And they're the patients that I'm thinking about doing tendon transfers or rebalancing for. They usually have better selective motor control and often more able to participate in the rehabilitation. Sometimes I have a patient who's GMFCS 1 or 2 that really has a heavily affected upper extremity that they have very little selective motor control over. And that's when I'm thinking something more like a wrist fusion with associated soft tissue procedures. The quadriplegic patient, I'm usually thinking, that, and they tend to mirror their GMFCS classification, soft tissue releases, sometimes joint stabilizations, but very rarely, if ever, tendon transfers. So this comes down to the area of interest of mine of how we assess success and how we assess impairment. And we're very good at as orthopedic surgeons, usually of assessing body function and structure. So we do range of motion, we can measure strength. We have a lot of patient-reported outcome measures, which are looking at participation. But for the upper extremity, I think it's particularly important to look at an activity-based assessment. And I actually really like the Shoei, which is the Shriners Hospital upper extremity evaluation. And the reason I like it is because it's a simple video-based assessment. It doesn't require high technical equipment. It doesn't require specialized training accreditation, and it doesn't have licensing to use. It's freely available and very easy to interpret. In terms of the patient examination, this is one I got from Dr. Ozaki, is it really starts on holding the patient's hand. If you sit there and hold the patient's hand whilst you talk to them, you'll get an idea whether their hand is quiet, whether it relaxes after you've been holding it for a while, or whether it's got that constant unease of dystonia and rest-based movement disorder. I do like to put the patient through an active range of motion, and I like in this to look at their selective motor control. I like to look if they can do the activity with one hand or they have to like mirror with their unaffected side to make the affected side work, because I think that helps me to understand how much control they have. And I also look at passive range of motion. The sensibility and size part I'm going to talk to a little bit more about, because I don't know that I base many of my decisions on this, but I certainly find that families have an aha moment when you do some of these tests in the office with their child, because they suddenly realize that the growth of the limb is different. If you put the two forearms up together, or you turn the child around and put the two humeruses and look at the length of them, you'll actually see that the affected side in a hemiplegic patient is smaller. It's smaller in length, and it's also smaller in girth. And Anne Van Heest has shown us that this magnitude is related to the degree of sensory impairment. So if you have a child with a great deal of limb shortening, then you can talk to the family about what that means. It's very visual and easy to do in the office. I also like to do a little office-based stereognosis test sometimes, because parents often don't realize that if you put a coin in a child's hand that's the affected side, they can't actually recognize it. So I use very common office-based items, and we'll show them all of the items to start with, put them away, and then just put them in their unaffected side first, and then put them in their affected side. Again, it just helps the family to understand that the brain is actually unable to process the same way. I do like 2-point discrimination. It can be very helpful. I don't use a 2-point discriminator. I use a paper clip that has been bent, and then I can just pull the tines apart. It's not as validated, but it's always available. And so this is how I do 2-point discrimination. And you'll find that in patients with cerebral palsy, 2-point discrimination is markedly different often between sides. Sometimes I do an office-based functional assessment, and this helps me with lots of things. The functional position of the arm when they're doing it, the ability for the patient to actually do that activity. So if you've got a 10-year-old and they can't, well, in Boston, zip a jacket, that's telling you that that child either hasn't learnt those skills or doesn't have the ability, and then it's my job to work out which one that is and therefore their therapy potential. It also sometimes helps me understand the family dynamic, because if the family immediately step in to help the child, then that also helps me to know that maybe some more assistance with independence can be helpful. So in terms of the non-surgical care, and I will say that this is the vast majority of my patients with upper extremity cerebral palsy, it's based around stretching and splinting, constraint therapy, which is where you take out of action the unaffected side. I will talk some more about this because I think it needs to be selected well. Bimanual therapy is just for often the more involved limbs, or after constraint therapy using the two hands together. Botox, which I think has had a very big use and continues to have use in the upper extremity. Phenol, which in general is not used in the upper extremity because all of the nerves in the upper extremity, apart from some of the branches to biceps and brachialis, are mixed motor and sensory nerves, and it has an astringent burning quality, so therefore it can't be used on mixed nerves. And then something a little about the spasticity medications. Stretching programs are what our therapists do all the time, and it's really just taking the joints into all positions. And we know that time spent at the maximal muscle length is actually a stimulus to normal growth. So this is trying to encourage decreased contractures. It really becomes part of the routine for these patients, so it's not usually something that I need to prescribe. However, I do talk about increasing the intensity when I know the growth spurts are going to happen, early childhood and peri-adolescence. I have had a number of parents for the late adolescent or young adult who has contractures who feel very guilty. And so sometimes I'll even let them know that even with really good stretching, you can still end up with significant contractures. Splinting, I think that this is really important to think about what the splint is being used for. I don't think that every child needs a splint. In fact, many patients do better without a splint because they then have the sensation of their hand. Functional splints during the day, I really like these Benic splints, which are a commercial brand, which are thermoplastically moldable, but there are many others available. And resting splints, I talk to the family about just that it's a prolonged overnight stretch, and then perhaps you don't need to do as much stretching during the day. But some kids can't tolerate it. They already have poor sleep patterns. And so in those families, they may choose to do an increased daytime stretching program rather than using a nighttime resting splint. As we all know, children go through various different stages of development, and at times they will refuse the splints. I actually get families just to put them away at that time for a period, because this is something that's going to be lifelong, and it's not always worth picking this as the battle. Intrathecal baclofen, you may think, well, why talk about intrathecal baclofen in an upper extremity talk? It does mainly cover the lower extremities. However, it is possible to place the catheter tip in a more cephalad position, and this can have some spillover effects into the upper extremities. But the higher it is, the more likely you are to have higher amounts of GI and respiratory complications as well. So it's just something to be mindful of. It just can be, if somebody has a lot of upper extremity tone, putting the catheter tip up a little bit higher does not result in a lower outcome, lesser outcome for the lower extremities, but can help the upper extremities. Botulinum toxin is very widely used within our service. It really does weaken the muscles, and through weakening the muscles, you get less of the stretch reflex. And there is some evidence that it leads to fibrosis. So it's certainly not something that I encourage high amounts of use in a child who I think would be a very good tendon transfer candidate. And we'll come to a randomized control trial that occurred, which actually really informed us about the value of Botox. I do have it used quite liberally in my more involved patients. And one of the good things about a baclofen pump is if you get control of the lower extremities, there may be sufficient dose, because a lot of these patients have fairly low BMIs, that their Botox dose is actually quite limited. In terms of constraint therapy, I am a big believer in constraint therapy, but it must be purposeful. It's not just taking that limb out of work for a short period of time. It's doing a focused program. And the one that I've come down to is using it for 3 weeks of constraint, followed by 3 weeks of bimanual. And in actual fact, where possible, our department actually runs, not this year, of course, because of the pandemic, but camps over summer. It's also a very positive experience for the kids to work with somebody else that has a limb just like theirs. This is what has convinced me that constraint therapy is valuable and should be used early if it's going to be used. It is valuable later in childhood as well, but it's most valuable when children are setting up their central nervous system patterns. And that it's not the same in every patient, how the brain reorganization occurs when you have a unilateral CNS event. Some patients will end up with both of their hands represented in the one cerebral hemisphere, and some patients will get bilateral representation of the affected side, and some patients will keep what most typically developing patients have, which is unilateral representation of each of their hands. It has been shown that this patterning changes after constraint therapy, and the change in the functional MRIs is maintained. And so therefore, we should harness that period in the first 5 or 6 years of life to really help to develop strong motor patterns, not at the expense of the typically developing hand either. I also think it helps us to select therapies. If somebody has only unilateral representation, doing constraint therapy is probably not going to help them. This is not something that we use on a daily diagnostic basis. So I'd like to ask our experts whether, in addition to these non-operative pearls, whether there are any other things that they've found particularly helpful when assessing their CP patients.
We can start with Peter.
Chime in if you can hear me okay.
Yes.
I think this was a great talk that you gave and a wonderful overview and introduction, and so thank you for that. You touched on it, but to continue to emphasize, trying to sort out what is the level of expectation that both the child, so when they're very young, it's hard to sort out. When they become adolescent, it's easier to define. But what's the level of expectation of both the patient who has the cerebral palsy, if they can convey it, and also of the parents, and trying to work through that as you make your way. And then the second, which I think you've already touched on, but the occupational and physical therapists to all of us are just essential, and their ability to help us assess this, particularly with kids who, as they get anxious in the office, have increased tone or spasticity or dystonia, etc. And then the only final thing I would add is the utilization, which you touched on, of video is just very, very helpful, both for formalized, validating scoring like Shoei, but also just gestalt. As you watch the kids and they do these tasks, you get a much better sense because the therapists usually put them at their best. But even sometimes I'll have families send me videos from home while the kids are doing things and just watch them as much as possible in their real life, not invading their privacy, in bathrooms or things like that, but just in life, how do they, put on clothing that still maintains their privacy? Those things to me are also really helpful.
This is Mary Beth. I'll jump in too, because I think that helping parents understand what their child is feeling and dealing with really helps set expectations on the parents' part. And from my time when I was dealing with adult head injury and stroke patients, I like to make the analogy for the parents, because most people know somebody in their extended world who has sustained a stroke. And if you explain to the parents that that child's hand is unable to feel, similar to when you've been sleeping funny on your arm and you wake up and it's totally numb, I tell the parents that you can't even get the top off of your toothpaste tube with that hand until the feeling comes back. And that's similar to what the children are feeling, that they don't have that sensation in there. And I think that's one thing that, as Carly mentioned, it might be a little bit of an aha moment for the parents to realize that, yeah, maybe that's part of the reason. I can't see that, but that's a real issue now. So I think that can be very helpful too.
Great. Anything? Oh. So we are now going to go on to, was there anything from our other experts that they wanted to share? Okay, we'll go on to the surgical care of the upper extremity next. So I talked before about how valuable I think that the Shoei assessment is, and I really like this. I'm going to show a very busy slide in a second, but I will break it down for you. This here is the Shoei assessment. These are just pictures of the items that you need to do a Shoei assessment. None of them are fancy. None of them are hard to come by. And it actually only takes, once somebody's facile with it, about 15 minutes to do. It takes a little longer to score. And it does report on a modified house classification, so just a score out of 5, not 8. It looks at potential use, so and also spontaneous use, which is important because there's a difference of what somebody can do versus what they will do. At Boston Children's Hospital, we report our Shoei assessments as a group with the occupational therapists. I sit down with them once a month pre-pandemic, and we have an upper extremity CP conference where we look through the Shoei assessments and make decisions together. It's really, to me, a nice form because it's one page and it sets out everything that you want to know. Each of the activities is assigned a particular segment. So the thumb and fingers are assessed together. The wrist is assessed, the forearm, and then the elbow. It really helps to look at what the alignment of the joints are, but you don't have to be looking at the whole limb. You're just looking at a small part for each one. And then down on the bottom right, you'll see that there's grasp and release function. This is really important for what's happening with the thumb and also the fingers, depending on what the wrist position is. Because if you all know that if you bring the fingers might be down when the wrist is down, but if you bring the wrist up to neutral, the finger flexors may be too short to now open. So I'm just going to show you some representative Shoei assessments, and remembering that 0 does not use it at all, and 5 uses it normally. And this is a patient who has, and it's usually used for hemiplegia, not for bilateral involvement. This is a patient that at best uses it as a passive assist. Most of the time they don't actually use it, or they just use their arm for paperweight function. So they don't have any grasp and release function at any position of the wrist. So this would be a patient that I was thinking more along the lines of joint stabilization, such as a wrist fusion. They're also very constant in how they're positioned for most of the activities. In terms of this one, you can see that this patient uses it a little bit better. Sometimes it can even be a poor active assist. Most of the time the hand is being incorporated into activities spontaneously. And again, we get a fairly uniform position that we've got the classic thumb in palm, fingers are straight when they're down in the flexed wrist position. So I always look at what's the wrist position, because the wrist position is not controlled when this occurs. And then you look at the grasp and release function in conjunction with the two. Ulnar deviation all the time, always pronated, and the elbow's always flexed. They can grasp and release when they're in flexion, but I know if I bring their wrist up to neutral, they're going to need some finger rebalancing. And so this is the sort of patient that I might be thinking about a tendon transfer, because I want them to be able to flex down still so that they can use some of that tenodesis to release, and also lengthening their fingers. This patient here was a very interesting patient that in the office presented having a very high degree of disability. But once we sent her for a Shoei assessment, you'll actually see that she uses the arm quite well, and in actual fact changes the functional position of the arm depending on the task. Further talking with this family it was actually a cultural problem that she had a hemiplegia. And so we actually didn't do surgery. We put in some training so that she could help to care for her younger siblings, which was actually what they were really worried about, and also her future as a wife. So when we think about surgical options, and this is another Dr. Ozaki quote, although I've added my own Lego touch to it, that we can decrease tone as surgeons. Predominantly for us, it's through tendon lengthenings, but I am going to talk about hyperselective neurectomy briefly. We can rebalance forces and we can stabilize joints. However, we are really just rearranging the furniture in a room that continues to tilt. And anyone who's a Harry Potter fan, this is the Weasleys' Burrow's house, which is very rickety. Something that I've become interested in, I do not do this, and I do know that there are some people in India who are doing this procedure, is selective neurectomy. This is a really interesting concept where you prune terminal branches of the nerves, which when you prune, you're doing mixed motor sensory nerves. So you actually decrease the sensory and motor supply. But because we know that motor nerves have the ability to do end plate sprouting, the strength returns, but the afferent stretch reflex is reduced permanently. So this is achieving quite a similar outcome to what a selective dorsal rhizotomy would achieve, except in the neck, if you're going to do a selective dorsal rhizotomy, you have to do it at every foramina because it isn't the cauda equina. It's reported to have similar indications and contraindications to most spasticity surgery. Again, something that I've become interested in, but don't currently practice. In terms of traditional orthopedic surgical timing, some people will operate very young, some people will operate later. I'm an in-between, I'm like a late adolescence person. I think it's the time that people can most participate in rehabilitation. But it's really about getting to know the patient, the family, the arm, the goals, and that everyone seems to be on the same page. And I'll tell you, seems to be on the same page because you can even still be a little bit caught out when you think you've gone through a very formal process. Some people talk about coordinating it with around lower extremity surgery. I haven't done that because most times plates are coming out from hip surgery around 10, and it's just not the right time in my practice for that. I think that it's important we're going to talk about single procedures, but it's very important to realize, and this is Dr. House's very large series of cerebral palsy operations, that on average, 180 operations were performed in 134 patients, and each patient had an average of 4 procedures per operation. So it's multiple procedures being done at once. And so it's really important to think about the balance. And I tend to think of the balance from proximal to distal, because as you come out, if you lengthen someone's elbow and you don't release their flexor pronator mass, their wrist is then going to become tighter. If you make their wrist forward, their fingers is going to become tighter and their thumb is going to become tighter. And so it's really important to think of upstream and downstream effects. In terms of the classic posturing, we all know the classic posturing. It's shoulder adducted, internally rotated, elbow flexed, wrist flexed, ulnarly deviated, tight finger flexors, sometimes swan neck deformities associated with tight intrinsics, and then the thumb in palm deformity with a tight web space. But lots of patients are not this. And so it's very important to look at what the individual patient is. It's very hard to apply a prescription to every patient. I'm going to talk about some individual procedures. I think that a pectoralis major lengthening, which is a release at its insertion onto the humerus, is an excellent operation. You can expect between 30 and 40 degrees of improved movement. Adding in a latissimus dorsi lengthening, fractional lengthening, which I do through a separate posterior incision, can give you an extra 30 degrees. I personally haven't been an advocate of doing many subscap lengthenings because it's not a 2-joint muscle. We know in cerebral palsy that the main muscles that are affected and short are the muscles that have to cross 2 joints. The patients that I've found help the most are those with GMF CS4 and 5 and difficulty with hygiene. And there are occasionally, and I'm going to say very occasionally, indications for other shoulder procedures, but these are the ones that take the most thought and probably carry a greater risk of not achieving what you hoped. Deltoid insertion elevation is for the patient who wings a lot. The global loss of control shoulder, I find very hard to know if or when I should ever intervene. Sometimes if an external rotation position could have an internal rotation osteotomy, or if somebody's got that position and they get an inadvertent humeral shaft fracture, maybe it's the time to roll them in and immobilize them in this position to get a fortuitous internal external rotation posturing at the shoulder. However, it has been shown that if you've got a contracture, you can actually usually improve that contracture by at least 50% of the static contracture. And I personally don't go into the joint because in general, cerebral palsy is an extra articular condition, and I don't want to cause excessive stiffness. And also some of our patients with head injuries are prone to getting HO. I tend to do it for contractures more than anything, and very occasionally for the functional posturing, knowing that I'm going to add a little bit of weakness, and I don't want to add too much weakness because people may very well use that hook function, or they may brachiate, which is where they hold between their arm and their body. This is something that Dr. Ozaki shared with me, that you can, if you stretch hard enough, you can actually cause a breakdown in the antecubital fossa. So I want to ask our experts, what's your preference in skin approach, and how do you avoid antecubital fossa skin complications?
So can we have Dr. Peter to answer that, followed by Zaki and then Jasmal and Jan?
So I'm happy. So I have gone to a transverse incision that's extensile for most of it, and I find that I can get both proximally and distally. Very careful in the exposure to first maintain all of the longitudinal veins, and so that the skin incision is made and the skin's very thin, and then protect the veins and make your way down layer by layer. Obviously, find the neurovascular structures, release the lacertus, depending on which way you're going to address the brachialis and biceps, and then if you're going to do something in the proximal forearm. It's rare, as you mentioned, will I enter the joint and trying to get that improvement. I think the other thing that, besides that slough that you showed, is that unfortunately I have been sent one patient who had a complete rupture of their brachial artery and became immediately avascular. And so you have to remember that at some point the artery and the nerve just have not been lengthened. So do a pretty extensive decompression of those so that they can have some element of flexibility, but pay attention to how much you can release at the same time. I hope that helps, Carley.
Can I jump in too? This is Mary Beth. Mm-hmm. I like a long Z-plasty, very, very long flaps. Here you go, Carley. You just set me up. But I agree with Peter that you release everything you can, and the rate limiting or the limiting structures are going to be the neurovascular elements. And sometimes those are just bowstrung out across that flexion aspect of the elbow. And from our experience with that patient whose father was, or his stepfather was an ex-Marine, and decided that he was going to stretch that elbow out. And that's how we came up with that terrible wound, which just increased pain, increased tone, increased the contracture. It was sort of a mess. But what we did to alleviate that was to use the brachioradialis as a flap to cover up everything along the anterior aspect of to cover the neurovascular bundles and everything on the anterior aspect of that antecubital space. If you extend your incision a little bit more distally, you can transect the brachialis tendon, or the muscular tendinous unit, and then develop dissect it back proximally to mobilize it, and then it will just swing transversely right across all those neurovascular structures and give you a beautiful soft tissue area that even if you Z-plasty flaps don't entirely come together, you still have good coverage over the important critical structures. So,
Great.
yeah.
Dr. Verthig? Oh, Dr. Sampath, I think you're on mute.
Yeah, Chasnal, would you like to? Yeah.
Yeah, Jain, sir.
No, I just use a standard lazy S incision. I've not had any problems with skin breakdown. But my main issue is how far do you go? Is it necessary to get a completely straight elbow? I rarely ever do. And if I can get them to 10, 20 degrees of flexion contracture, I'm quite happy with that. And I have a few questions on the same issue. And most of them are worried about the posturing that happens. And I've not been so successful, even though for function, they're able to get better extension. Many of them, even after Z lengthening, they do tend to posture, which I feel is neurological. What is the experience of the other the faculty about does posturing improve? What do we tell the parents when we do a Z lengthening of the biceps? Dr. Vuillermin and Dr. Waters.
Carley, why don't you answer?
Yeah, I actually had this discussion with Dr. Waters only a couple of weeks ago. I haven't done very many because of that, the knowledge that it can be very hard to actually address the underlying problem. There is certainly good literature about going up and stripping the paratenon and the muscle belly up a little way so that can decrease some of the afferent stretch reflexes. And so therefore, I think that makes sense to me. Also, I'm worried about with a Z lengthening, the amount of weakness. And so therefore would probably do more of a fractional lengthening in a functional elbow and more of a Z lengthening or a complete release in a non-functional elbow.
We have
Doctor.
Go ahead, Dr. Waters.
I just add to, I think the other question you'd ask is, do you get complete correction? And I think that's rare. And one of the worries is if you get too much correction, they may lose some of the elbow flexion that they need for function, because many of these kids brachiate, so to speak. They utilize their upper arm and their elbow to help them, and that strength helps them. So I agree with you that I don't think you're going to get the arm all the way out straight. But if you get a significant improvement, they'll keep their function, not have a problem. This will probably come up even more when we get to the hand. We're just not smart enough to fix their brain. And so some of this just isn't going to go away because we're operating in the periphery. We can make them better, but not completely so, because of the central nervous system problem still exists.
Yeah, I think that a lot of the posturing is actually because of balance issues and trunk support. Because if you think about when these kids are posturing, they're either trying to maintain a sitting balance in a wheelchair, or they are trying to ambulate or to get from point A to point B. The reasons that I would do some of these more aggressive elbow releases are not so much for a functional range of motion of the elbow, but more to get the forearm onto the arm of a wheelchair to help trunk support, to extend the elbow to make it easier for their caregivers to get that arm through the sleeve. Not so much of a problem in Texas, but certainly a problem in Boston where it gets very, very cold. As this was my patient that Carley is showing. I think that was my patient, Carley. But yeah, and this points out what Mittal had written about, that, in doing an elbow flexion release, you at most get about 40 degrees of improvement. It's very, very difficult to get any more than that unless you go to bone and try to do an extension osteotomy. If you ever have to do that, by the way, shorten the humerus. It makes it a lot easier. Thank you.
What about serial casting after an elbow release? Doing a conservative release and then gradually stretching it out over time. Would that be a more guarded approach?
I haven't had a patient who tolerates.
I have used serial casting after with good effect. We've got a nice serial casting protocol going now, which is having a better outcome than our previously more ad hoc approach to serial casting.
What is your serial casting protocol? You could share with us.
So now all patients have to have an occupational therapy assessment prior to starting serial casting. The actual serial casting is run by the occupational therapist. The brace that the patient is going to go into at the end of their serial casting is ordered before the serial cast, well, during or before the serial casting starts, so that it's available at the end of the serial casting. And then they get molded into their brace at the end of their serial casting, so that they immediately have a maintenance program in place, and then they have follow-up occupational therapy.
Dr. Taral has, oh, okay.
Carley, can we continue with the lecture and then we will take the question at the end?
Wonderful. So the next...
Carley, this is Mary Beth. May I make one more quick comment about the shoulder? You mentioned a pec major lengthening. Sometimes it's actually very difficult to get that arm onto a table, onto the operating table, because of the internal rotation contracture. And there's a little technique that I learned. It's similar to a percutaneous TAL lengthening, if you think about it, because the tendon of the pectoralis major is on the posterior aspect of the muscle. And if you put it on stretch, you can actually slip a little 15 blade in percutaneously. These kids are never fat, but you can slip it in percutaneously and just lengthen out some of the tendon at the musculotendinous junction, which helps with both the pec tightness and also getting the hand onto the table. So thanks.
So moving down the forearm, pronator teres is often a deforming force, and a pronation contracture is the most common presentation. Tonkin and Gershwin have helped to inform us about when we may consider releasing versus rerouting. Some people advocate an osteotomy in a hyperpronated position. I personally have not done this in cerebral palsy. And it's also important to remember for the pronation contracture that if you're doing a traditional FCU transfer, because it's coming around the ulnar side of the ulnar onto the dorsum of the wrist, it actually will act as a supinator. And so FCU transfer can be part of a pronation contracture release, a pronator contracture treatment. I just want one word answers from each of our experts as to whether they tend to be releases or rerouters. I know everybody selectively chooses, but people tend to fall on one side or the other, or if you're truly 50-50, that you're 50-50.
Rerouter.
Yeah, Peter, please.
Rerouter.
Great.
Yeah,
Rerouter if there is passive, if you have some passive supination at the table.
Samba?
Yeah, Chasnal, what is your...
So I reroute every time. I don't release. I released a small number of patients and did not get good results. So I went back to rerouting again, because the literature has been very on and off. It just keeps coming and going. So there was a paper that said there was no difference. So I stopped rerouting, and then my results are not so good. So I'm now, over 20 years, I've changed twice. I'm back to rerouting again, and I'm happy.
Mm-hmm. Dr. Rathik?
I think Tonkin 1 and 2, they do good with release, and probably the Tonkin trend grade 3 onwards, a rerouting would be a much more better option.
Mm-hmm. This is again I just want from our experts, are you thinking do nothing for this young lady? She wants something. Would you do a tendon transfer for wrist, or would you do a fusion?
What's her passive wrist extension?
30 degrees above neutral.
And passive
And she looks
supination?
like an older adolescent. Maybe
She is an
15,
older
16.
adolescent, that is correct.
Carley, is she able to extend the fingers with extension, or do they kind of flex? Or
She has grasp and release function with her wrist flexed and at neutral.
neutral? Okay. Yeah.
I would do a tendon transfer. In pronation, the ECU, extensor carpi ulnaris, is a pure ulnar deviator. And my preference would be to transfer the ECU into the ECRB.
Great. Would anyone, rather than an ECU transfer, because she seems to have fairly good selective motor control and she seems to be quite only deviated and flex, anyone just on this video, which is very hard to commit to, would you think of doing an FCU, more of a traditional green transfer?
And that's the procedure I have experience with. Again, there is a divergence of opinion between FCU and ECU. I think ECU is now making a resurgence, but I'm afraid there's no comparative literature at all for us to choose between the two. So I would love to hear from the experts about how they would choose between a FCU or ECU transfer. Are there any factors you would use in your decision making?
So, Carley, do you use an EMG to decide if you want to use the FCU, even if you think that it has a very good selective motor control? Do you think an EMG plays a role here before doing this transfer, or like how would you decide? And even from the
I agree that EMG assessment would aid in my knowledge to make the selection. Our gait lab is actually at a different facility, and so therefore we have to use neurology. I've tried to set it up, and so I haven't had access to that. Although Dr. Van Heestet has had very good and has written about this a number of times about whether something, you don't want to transfer a muscle that's tonically active. The best FCU transfer to do is one that's completely out of phase, because then you're taking a wrist flexor and making an extensor, and it's going to fire when it should be an extensor. But even if it's in phase, it can still be utilized. But we found that it doesn't change phase. So I agree, EMG would be very helpful. It's not something I currently use in my practice. Okay. So I actually, I don't think I've got the outcome for her. I did actually do an ECU transfer. I think that I was worried about overly correcting her, and that she seemed that her FCU seemed tonically on. I didn't feel that it was phasic. But it's very hard to make that judgment from a short video. This is another patient of mine who is also a hemiplegic patient. I'm going to ask the experts whether you would transfer, fuse, or do nothing. She really wants something. She really, really wants to go to her first job interview and not talk about her right hand.
Shall we start with the Chasnal first?
I think probably, Carley, I think, you think she's purely spastic, or she has a dystonic component maybe, or just in case if you want to let me know that. And I think that's a much less non-functional hand. She's not even using it to like kind of support the paper. So probably I would like to go for a Shoei scoring and understand her spontaneous functional activity. And if it's somewhere about 40% or so, probably then an operative thing could be planned. Or maybe before that, give a trial of a splint and look for any finger function or grasp and release, and then plan for a procedure, because I think hand procedures are much more complex, and doing a trial of splint, cast, or maybe even a Botox can give us better idea in getting better outcomes from transfer instead.
Perfect. I think that's a great summary. So we might not just skip our other experts, but come back to our other experts later. She was actually the first Shoei that I showed you. So she had no grasp and release function. She'd had a number of splinting, stretching, serial casting. And so therefore, for her, I actually did a wrist fusion. And wrist fusion really has been shown to be very helpful in the lower functioning hand to provide stability. You still need to do the soft tissue procedures in order to rebalance the hand. Otherwise, you'll end up with either tight fingers or a lower functioning hand than before. But it has been shown to improve hygiene and also improve satisfaction. So this is her hand after fusion. This was only about, I think it's 4 months after fusion. I've taken her plate out now and she loves her hand because she can actually use it better than she could before as an assist. She actually does have better finger movements now. Not great though. She's more hypotonic, but mainly spastic, not dystonic. So she has a very low tone hand without dystonia. So that's how I made that decision for her. You'll note that I set her wrist at neutral to slight flexion. I don't put my cerebral palsy wrist flexions in any extension like you do for an adult degenerative wrist fusion. I also think that wrist fusions are very good utility in the patient for seated posture and also dressing and hygiene. Even if you do one arm, it can be very helpful because then you increase the mobility of that arm so that the family are only struggling with one contracted arm. This is a patient of mine. We'll skip over that because we're running a little short on time. I'll make sure that we get to
Carley, can I just go back to your wheelchair patient just for 1 sec? So I agree with you, wrist fusions can be very helpful. As you and I have talked about, I think you got to be very clear on the fingers because you don't want to develop a finger contracture, as you bring the wrist up. The other thing that comes up is some of these children, even the severely involved ones, can make a motorized wheelchair go. And so that they use that wrist flexion sometimes to drive their chair. And so I think you got to be very careful of that. You can make them straight, but you may make it harder to drive versus others. When you stabilize their wrists, they're better at driving. And so I think you got to look into that. And those are things you already know, but I just wanted to point out if that's okay.
That's great.
Carley, can I add one little quick tip about the fusion? When you use the plate, as you did in that, usually the plate goes onto the third metacarpal. If you do not do something with the tone in the flexor ulnaris, either by doing an intramuscular lengthening or some sort of a release procedure, the FCU inserts distal to the carpal metacarpal joint, and the ring and small carpal metacarpal joints are mobile, and you're going to get a recurring contracture through that joint. So just a little tip when you're trying to deal with a wrist fusion.
Absolutely, very wise. In terms of the adduction contracture, almost all patients will have an adduction contracture. We know that there's the House classification for the thumb, which is different to the House classification of functional use. But the procedures that I've found to be particularly helpful are a first web space deepening, which I use a 4-flap Z-plasty, either a thenar slide if I don't need a 4-flap Z-plasty, or a thenar release through the web space. And I think the EPL rerouting has very low morbidity and very good effect on changing the EPL from being a thumb adductor in a spastic hand to taking it back to being an extensor and abductor. So I do a 4-flap Z-plasty. I know that Dr. Waters likes to do a 2-flap Z-plasty. I like the 4-flap because it gives a smoother web, but Dr. Waters may want to tell us why he likes the 2-flap.
Sorry, I had to unmute. So I will tell you that I started out doing very, very fancy 2 parts, 5 parts, etc. flaps. A lot of the kids with hemiplegia have very thin skin, and I think their flaps are a little bit precarious. And what you don't want to have happen is to get a flap necrosis and have it scar back down. So I found that the wider 2 parts just gave me better flaps, better vascularity. So that's reason one. And then reason two is I'm, like you are and others, I'm a big multi-level surgical person for the upper limb. So going from elbow to forearm to wrist to fingers to thumbs, a lot of surgery. And I like to get it done in one tourniquet time of less than 2 hours. So the two-part actually lets me also move faster, safely, without jeopardizing the outcome. So those are my two reasons why I switched.
The other problem that we find commonly in our patients who've had a thumb adduction contracture all of their life is thumb instability. Dr. Rathod, I might just ask you what you might do with this thumb that's clearly got an adducted. I'll tell you that there's thenar spasticity. There's a pretty good first web space, but there's this really hyperextending IP joint.
Yeah, Maribeth, would you like to answer the question?
That's a little bit more unusual than having the hyperextension at the MP joint. But I think in this situation, if you can bring the thumb ray out of the palm, the long thumb flexor is going to assume a better ability to flex. And I don't know that I would do anything immediately with that IP joint of the thumb at the same time that I'm releasing the thenar muscles and bringing the thumb out of the palm. If the deformity is mostly at the MP joint, which is a little bit more common, what I like to do there is stabilize the MP joint with a sesamoid fusion, and then also bring the short thumb extensor and do a tenodesis to the metacarpal neck. It's a little bit of a tricky procedure, but it works beautifully if you do that at the same time that you're bringing the thumb out of the palm.
Yeah. So in general, you're either looking at capsulodesis or sesamoidesis type procedures, and the metacarpophalangeal joint is much more common than the interphalangeal joint. And fusions traditionally have been the MCP or the IP joint fusion. I always worry that if I fuse, but I don't solve the thenar balance, that the fused thumb is then going to end up pulled into the palm as well. So I haven't been a great fuser as yet in my practice, but my practice is still young. For this particular patient, I actually did an EPL rerouting, and the couple of extra scars over the back of his thumb is that his EPL had some tethers as I was trying to reroute it. But I tenodesed his EPL to his proximal phalanx so that he got he could still bend, and I did it at 30 degrees of IP flexion. He could still bend, but the EPL was then actually a proximal phalangeal extensor because he did not have MCP hyperextension. And so he actually ended up, and he has quite a dystonic hand if you look how many swan necks he had. So I'm not sure that we have time to go through how much lengthening you get from each of these from our experts, but intramuscular lengthening you can get between 1 and 2 centimeters, and then adding in a second lengthening up to 3 centimeters of lengthening for forearm flexors. Z lengthenings in general are reserved for the FPL, not for the digital flexors, because the superficial profundus transfer can be performed. I personally don't use the superficialis to profundus transfer in CP because it often ends up in a very intrinsic plus hand situation because it's such a powerful release. And then the flexor pronator slide is in between, which will be 5 to 10 centimeters of lengthening, but again, not as common. For me, most of my patients get intramuscular lengthenings. So in terms of the single event multi-level surgery, which is what Dr. Waters has talked about, and it was mainly coined in the lower extremity in CP, but it's been being done in the upper extremity for many years. It's a single simultaneous surgery with multiple procedures. And this is a great paper if anyone's interested in looking at surgery versus Botox versus therapy alone. And it actually showed that the patients with surgery did better with strength and had more sustained results. For me, who's most likely to benefit from upper extremity cerebral palsy surgery? Hemiplegic patients with high function, hemiplegic patients with wrist deformity with lower function and quadriplegic patients with contractures. I'm just going to give a few pearls, which actually I'm very glad that our experts have mainly talked about already. One is that the shoulder alone may not be the major deformity. However, it's a total deformity in both limbs that affects dressing function. And so therefore a pec release, which is a fairly small procedure, can have a great deal of impact for somebody's day-to-day hygiene and care. This is, if you do need to do an internal rotation osteotomy, and Dr. Ozaki said, if you need to get all the way to bone and you're doing something to the bone like a flexion or extension osteotomy, take a piece out. When we're doing it in plexus, we're doing external rotation, so we're decompressing the radial nerve, but an internal rotation osteotomy would potentially wind up the radial nerve. So you take out a section, helps to decompress the soft tissues. Dose the elbow according to function. Be careful if the patient's externally rotated, otherwise their arm may become stuck at doors. And that we've already talked about that the loss of elbow flexion can also be disabling. So don't go so hard that you get it fully straight that it won't bend. Wrist fusion to me is an absolute winner for the right patient, but it takes a lot to get the soft tissue balance right around the wrist. Don't put your wrist fusion at 30 degrees of extension. Functional hands I put at neutral, and seated hands I put at 30 degrees of flexion. And I always leave seated hands in the pronated position because that's actually how we sit. We don't sit with our hands with our palms up. This is another Scottish Rite rule that I love, which is the 2-4 rule. We're not doing surgery to the patients, we're doing it for the patients. And that it will be a very hard decision, and that the tilted room of cerebral palsy will still be there at the end of the day. There's a lot of information to gather before we actually undertake any surgery, and that a comprehensive approach is needed, but not to neglect the upper extremity just because it's difficult. It's actually, to me, the most satisfying part of my practice. And I think that over and over we've said, select treatment according to realistic goals. Thank you.
Yeah, thank you, Carley. There are a lot of questions for you. So I will start with one by one. The first question you mentioned about the dystonia, that dystonia is one of the components where you would not like to operate a child. So can you quantify, how do you decide like this much amount of dystonia I will not operate, or this much dystonia is okay for surgery?
It's a very hard question, and that's where I think you need to get to know the patient and the limb. And it may be that you do some surgery like I did, that thumb rebalancing, which really gave him a nice stable post to use. I think that, you know, it's a little embarrassing for me to give some of this advice because it comes from my mentors who are my experts here today. But really understanding if that limb has motion at rest, or if it is spasticity, which is tone related, can be very helpful. And another pearl that Dr. Ozaki taught me was about the pointing finger. The pointing finger is telling you that that patient has dystonia.
Okay, the same question related to sensations, like a poor sensation is one of the factors where we don't consider for a surgery, or like that suggests a poor function even after surgery. So like after checking the stereognosis, how do you make your judgment? Like if patient fails to like 6 out of 10, will you consider for surgery, or 2 out of 10? At what point you will say that this is not the right candidate for surgery?
So I personally don't use stereognosis as a criteria for surgery because I use the Shoei Assessment, which looks at spontaneous functional use and maximal functional use, or dynamic positional analysis as it's called. I use the stereognosis and the 2-point discrimination as a tool to help families understand. And it hasn't been shown that, and in Dr. Van Heest and Dr. James's study, they didn't find that stereognosis was correlated with outcome. And so therefore I don't particularly use it. I don't know whether others do.
Okay, yeah. Maribeth, would you like to add something on sensation part?
Can you hear me? Yeah.
Yeah, please.
I think I think the sensation is an important thing to consider for your expected outcomes, whether or not the patient will use the hand. If they don't have adequate sensation, they will not use the hand. But there still may be other indications for proceeding with surgery as far as improving the hand as a moderate assist hand. You may improve the position of the hand for seating, for hygiene, for dressing. So there are lots of other indications, but the lack of sensation usually correlates with volitional movement and volitional use afterwards.
Okay, then Taral has a question about, like, can we use a brace or a cast to correct the elbow flexion deformity, the stretching cast? Every 7-10 days you change the cast and you make the elbow more extended. Can we use that for correction of the elbow flexion deformity?
I actually think I've used it quite a number of times for elbow flexion contractures, and especially when they've accelerated during a period of accelerated growth. I think you can really catch up on the stretching through a period of serial casting.
Okay, yes, Maribeth, would you like to add something on that, or you also agree with the same?
It's a temporizing measure. So I think it can be helpful, but I don't think it will be permanent. And at some point, my experience is at some point, usually by then the teenager just says it's not worth it. They tried it, didn't work, done.
Okay, then there was another question, which is, I think, Maribeth, you are the right person to answer that question. In stroke patient or head injury patient, one of the surgery which is suggested for the wrist or the finger flexion is forearm bone shortening. We shorten both radius and ulna instead of lengthening the muscles. Now, why that surgery is not being used in cerebral palsy?
I don't have any experience with shortening the forearm, but I would suspect that the reason not to use it in cerebral palsy is, especially if you have a child who is still growing, you want this limb to grow to its maximum potential because they already have the neurologic effect that causes the limb to be shorter, as you saw in some of those earlier slides. Parents don't usually readily accept having something made worse, if you will. If it's already short, why make it shorter? Yeah.
Okay. Yes, Dr. Waters, would you like to add something on that?
So I do, like Dr. Zaki, I don't have experience on shortening the forearm. It's an interesting question of how you get there, but I do think it somewhat depends on the age at which you do your surgical interventions in terms of their skeletal growth. So I think that's important. I wanted to add one other thing that came up about the serial casting is that there are a number of times where we use dynamic splints to try and help us with contractures. And in the presence of spasticity, I would probably discourage dynamic splints because it oftentimes sets the spasticity off more, whereas static casting correction seems to be more effective that way.
Yeah, thank you. Chaznal, yeah, your question.
So for the stroke, in continuation to the stroke in children, Dr. Izaki, many a times we see even after the fractional lengthening in the forearm, the fingers still don't get to have very good function. I mean, in spite of getting to the neutral position, the grasp and release is not as good as we would see in kids with cerebral palsy. So what are the additional things like you would suggest for a child with a stroke to get more active function apart from correcting the deformities which were much more severe in a child with stroke? So
that's a great question, but I don't know that I've seen enough patients to be able to distinguish from a later stroke during childhood versus the antenatal stroke that was the usual cause of cerebral palsy. We do see a number of kids who've had traumatic brain injury, and those are very, very difficult to get any kind of control. And probably the worst types of spasticity are those that occur after a hypoxic brain injury, say a near drowning, when those are extremely difficult to deal with. So it has to do with the level of the brain injury and how focal or how widespread it is. I think my approach surgically and decision-making wise would be the same as what we've outlined here, and maybe modifying the expectations to better hygiene, better facilitating custodial care.
Yes, Saral, can you ask a few questions like you have, which you have received on the WhatsApp?
Yeah, so one of the question I had was that a lot of children they compose when they become adolescents or young adults, and those who have deformities, but they are adapted to those deformities. And if you operate at that age, how well they respond to that surgery. They quickly adapt to the corrected position, or should we operate them or just leave them alone? That's the question. So I'm going to ask Dr. Ezaki first, and then Peter, and then Carley, in order of their age, to answer this question. The most experienced first.
Wait a minute. So you're saying that I'm older than Peter? Thank you. Good for you, Peter. All right. So the question for the older kid, especially the teenage kid who has a deformity, a lot of times they're looking for some sort of psychological remedy. You have to figure out if they're using the hand in some fashion, can you do something little to change the position in which they will use it better? Or is there an underlying psychological problem? And if you get into the young adult, particularly a working adult or somebody who's in college already, I would really try to figure out what the psychological issues are there before because I can't cure psychological problems with surgery. So I would go at that. Peter, there you go.
All right. So I think this gets to questions that I've been seeing a lot in the chat, is the timing of intervention and benefits in both directions. I think you have to, when you go early, you have to take into account what growth is going to do to the intervention and to that limb over time. And so sometimes and I think you only get one really good chance at this if you're trying to do tendon transfers and rebalancing. I think repeat operations are not quite as successful. So the second is, I think you get into motivation. And so the negative motivation Dr. Ezaki was just touching on, but some of the young kids, when they're young, they just want their parents to leave them alone, and the parents are greatly concerned about how they look. And then later in life, they become more concerned about how they look or how they function. So I think there's a spot where you can potentially help them if they're motivated in a positive way, not necessarily a negative way. So that's where these patients take a lot of time and energy, and having other people sort through this with you, I think, is very important. It's, I don't want to say easy, but it's not hard for our part. The surgery we can do, it's really what impact do we have on their lives. And our goal is actually to try and help them be better functioning adults. So with all that as background, I actually find kind of early teenagers a great age to operate on if they're the right kid. They're highly motivated. They're definitely going to participate in their therapy. And oftentimes, I think you can get a very good result if you understand what they want.
Because one of the big problems for us is the logistics and cost in India. So we are very often tempted to time the upper limb surgery with the lower limb surgery, because it will greatly reduce the amount of total expenditure in terms of the surgical cost and the rehab, because most of the healthcare expenditure in India is out of pocket. So those are all, completely extrinsic factors which do influence the decision of surgeons to try and, so we typically do lower limb surgeries now between the ages of 9 and 11. So my own experience is that we are doing the upper limb surgeries at the same time, purely for no other reason other than just the logistics of it. Is that wrong, or it's not, it's not wrong? It may not be the best thing, but I think children are pretty much, their brains are switched on by 10, 11 years of age. What would you say to
that? Many factors weigh into the decision making, and I think that certainly local health service factors certainly do. My practice now is different to what it was in Australia. I don't think it's wrong, or I've always stayed away from it because I've worried about competing interests in rehab. that a lot of the children who are ambulatory and have lower extremity surgery use a gait aid in their rehab. And so I do worry about the competing interests in rehabilitation, but we don't have that competing interest of the cost being borne by the family. So it is a difficult decision.
So we have question about the swan neck deformities of the finger. So which procedure is like more recommended, an FDS stenodesis or a central slip tenotomy? And like Dr. Peter Waters said, that we are always running or trying to compete with the tourniquet time. So which one would you recommend? And would you want to classify them as intrinsic or extrinsic, or how would you go about? So we can first have Dr. Peter Waters.
So I'll start. I think for lots of, like for intrinsic problems, I like the FDS tenodesis, but in the CP kids, I have tended to use a pretty simple lateral band rerouting, where you make an incision along the edge of the lateral band and bring it volarly and sew it in. And I think it makes actually a very good tenodesis, and it's as we talked about, you mentioned, it can be very timely.
Yeah.
I have been disappointed, to be honest, in the central slip tenotomy. I love that paper. I thought it was going to be great. And the few that I did, maybe I just did the wrong kids. Maybe I didn't do it right. But I went back to my lateral band rerouting, which I thought was pretty reliable after that. So that was for me. So that's what I tend to be. The second, which I think came up in the chat room, but one of the things that does happen, Carly and Mary Beth mentioned about dystonia and what happens, but when you do an extrinsic operation, you sometimes unmask intrinsic problems that you were not as well aware of unless you had been really paying attention. And so suddenly you get this hand that looks like it's a clenched fist, tight fist, that's now stuck with MCP flexion and IP joint hyperextension. It's always nice to try and figure that out before surgery rather than after surgery. Is just a comment on what you got for intrinsics, because they're a little more complicated.
Yeah. So Dr. Izaki.
I would also consider an intrinsic release. Especially if you have MP flexion in addition to the swan neck deformities, because sometimes that can help. Relatively easy to do because you can approach those between the metacarpal heads and reach in, usually with a skin hook, and just pull up the intrinsic tendon and release those, and then lots of splinting afterwards.
So would you use the stainless steel wires or a regular suture? What is your choice of suture for the tenodesis in case, for the FDS tenodesis in case you want to do?
I find stainless steel wires a little bit difficult to handle, so a non-absorbable suture would be fine.
Okay, Carly, you want to add something to this?
No, I find swan neck deformities and the intrinsic extrinsic balance something that I spend a lot of time thinking about before, during, and after. And I currently have a family who've come back to me and they had surgery with somebody else, and at the moment I'm trying to work out how to salvage this very intrinsic plus hand that's got these swan necks that are really starting to dislocate because of the tightness of the intrinsics. And so I think it is a really hard problem.
So anytime you would want to splint them, like a Kapner splint or something, like, do you all recommend that?
I've used overlate or silver ring splints, but overlate to the less expensive plastic ones.
Yeah.
More as like if somebody will wear them and they'll wear them all the time, then I think they're going to be a good candidate for like a lateral band transfer, because it actually means that bringing their finger into that flex position helps them. And I think it's the same with other upper extremity splints. The proportion of my patients that really like their splints is probably 15 or 20%. And I think they're the 15 or 20% that really get a functional gain from putting their splint on.
Carley, there is a question by Dr. Rujuta Mehta, and she wants to know about PROMISE.
So PROMIS is not really validated for use in cerebral palsy at all. And what we have found with many patient-reported outcome measures is that patients who have developmental disability do need specific outcome measures. And so therefore, the work that I've done with PROMIS has actually been with our brachial plexus patients. And for people who are not aware of what PROMIS is, it's a patient-reported outcome instrument that was developed by the National Institutes of Health here in the US. And it actually pulled questions that had been used in prior patient-reported outcome measures. And it uses something called item response theory to actually come up with the score, which means that if you say that you can run 500 meters, you won't be asked, can you run 5 meters, if you use the computer adaptive portion of it. There are also short forms, which in my research I found came to the same answer for the population, but were not as discriminant on the individual patient, whereas the CAT is more discriminant for individual patient use. But it's a standardized score where 50 is normal and a standard deviation is 10. And so 95% of the population will be between 30 and 70. But it does have the ability to have tails, whereas many of our other, like the POSI has a very low ceiling effect. Like many patients score fully on a POSI assessment. So that's, the PROMIS is just a nice modern, and it's actually freely available for use as well, which is what I think is another great benefit of a patient-reported outcome measure. And it doesn't require training to administer.
So is there any specific patient selection for that?
So the patient normalization was done on typically developing patients. There are different modules, but it's meant to be administered to typically developing patients. But like there is an upper extremity module, there is a mobility module, there is a depressive symptoms, there's pain interference, and each module only takes about 1 minute to administer. So it's actually,
that's great.
You can pick out just a few things that you think are important to your practice, or you can just administer certain domains to patients that you think it is most valuable to.
Okay, before I hand over to Taral for our journal, the last question is about what is the role of selective neurectomy in the upper extremity? You mentioned in your lecture, but do you use it really in the practice, or it's just
No, I mentioned it specifically saying that I don't use it, but I think it is very interesting. Just as selective dorsal rhizotomy for a very selected group of patients is excellent to improve their gait and mobility, I think that in the upper extremity, selective dorsal rhizotomy is not, but doing it in the periphery can achieve a similar outcome. And Dr. Leclerc's research in this area, Carolyn Leclerc, has been, to me, very interesting. I watch it, I'm not ready to do it yet.
what do you think, Dr. Peter Waters, about this? Like, do you consider this as a promising surgery, or it's just one fashion, like which is going to pass away in due course of time?
I don't know the answer to that. I'll be quite honest. There was a time where I was really, I thought for example, some of this intrinsic, there had been some work done out of Southern California on selective motor branch of the ulnar nerve neurectomy. And I just thought that was going to be spectacular. And so I would try to block it with local anesthesia and see if there would be improvement, and if so, do it. And it just didn't work out quite as well as I thought it was going to, is all I can say. I don't know if Mary Beth has any comment on that, but I'm always hopeful.
I think you're muted.
Yeah, Taral, now it's up to on you for the vote of thanks, and then for our inauguration of our journal.
Great.
Okay, so big thanks to all the speakers, the panelists, and the people who have been watching for this wonderful webinar. We could lay our hands on the most difficult topic in cerebral palsy. And the debate is going to go on and on, but we found more answers. Of course, we have answers which can be questions and questions which could be answered. I want to invite Jayant with this to unveil his new baby, which is the International Journal of Pediatric Orthopedics. Jayant, I'm going to share the cover page and then please speak and tell people about this journal. Jayant, Sampath for you.
So IJPO is not my baby. It's a collective effort of about 30 people who are all members of the Pediatric Orthopedic Society of India. So this is our official journal, and this is the first issue. So we have contributions from 3 continents. We have original articles from Japan, from India, and from the UK, and some contributions from the United States. So it's a very, it's baby steps, but we hope that the journal will receive more viewership, more recognition in the years to come, and we will be able to be recognized as a mainstream pediatric orthopedic journal. We are looking to the established